if you don't. Okay, so if you don't want your faces on the recording, then please just turn your cameras off. We're gonna, as Simon's just said, we are gonna look at just making sure any questions for Matt is around health rather than any school operational guidance. So any questions for Matt, please do use the chat. But if you have got operational questions as well, please use the chat, but we'll deal with those in the second half of the Coronacast. So if you please could keep your mics muted, just so we don't get any interference, that'd be great. Okay, thanks.
Okay. And is Ray with us today, or?
Ray, I haven't seen Ray yet. No.
Okay.
So Joe, got questions?
Joe, you okay with questions?
Yeah, no problem.
Yeah. Okay, that's great. Okay, welcome everybody. Welcome to our Coronacast. So we are going to have an extended meeting today for an hour. Now there may be more questions and we've got answers to at the moment, because I know I've not had a chance to meet with our director, our public health lead yet. So what we will do is, if there's questions we can't answer in today's meeting, we'll schedule another meeting, perhaps Friday, where we can get back to you as well. So welcome. Delighted that Matt's joining us today. We met Matt 4 weeks ago. He was sitting in a sunny garden in Cambridgeshire, but he's back in work today. So I've got a few things I want to talk about with Matt. So we always start off, Matt, with the question about it's only 4 weeks since we last met, and you gave us a kind of a glimpse there of what was to come, because many of us had just come back off half term. We'd had minimal disruption in our schools, and you started to tell us about the Delta variant and how it was more transmissible and the challenges for running schools. So are there any updates medically around the variant since we last met?
So I suppose the major update is that we're getting data all the time from Israel, and Israel's quite a good test case, because it vaccinated its population quite early on, and it used a single vaccine as well, which is the Pfizer vaccine, which out of all of the vaccines has been the one that's generally tended to come out with highest sort of efficacy estimates, and we've used it fairly heavily in the UK, including for the majority of the under 40s, so it's quite a good comparator. Unfortunately, what it did show is that we're probably starting to see waning immunity in Israel. So if you think back to when Pfizer was first announced, we were sort of talking about 80 to 90% effectiveness, and obviously that was with the wild type, and then similar efficacy to the alpha variant. Now that Delta is the predominant variant there as well as here, they're getting mainly around sort of between 60 and 70, the estimate being 64% efficacy for infection. Now obviously infection is one thing, hospitalization and death is another. It still does seem to perform very well for hospitalizations and deaths, perhaps a little bit less effective than what we were initially thinking. That probably is to do with a number of things. Firstly, Delta seems to be quite good at evading vaccines, or a bit better than the previous variants. It's more infectious, so it's finding more people that in whom the vaccine hasn't worked, and unfortunately those that haven't been vaccinated. And I think also just the waning immunity. There was good evidence from the Crick Institute, which is a big sort of cell biology of infection lab in London, looking at neutralizing antibodies. So they're the sort of the most potent antibodies that stick to the virus as soon as it enters your system and tries and neutralizes it. And they showed that in the most vulnerable groups, which are mainly the over 80s, that they already were seeing waning immunity levels in about half of them. So I think, given that Israel vaccinated its population quite early on, I think they're starting to see the fact that we are going to, come the autumn, we are going to have to start giving booster doses. And I think that comes on to perhaps a bit of why we're in the situation we're in now. And I've been trying to think of, because obviously back then we were thinking of 19th of July, sort of moving to step 4. I think what we're now talking about on the 19th of July is sort of step 4+. So really we are throwing open the doors to infection in those that aren't vaccinated, or in those that have only had one vaccine dose. And thinking about it, I think there's probably a number of reasons. Obviously, I'm not party to a lot of the statistics on, say, how much vaccine we actually have, but reading between the lines and looking back at the last couple of weeks, you can see all this data. It's available on the coronavirus dashboard, but actually we've been vaccinating around about 50% of the people we were vaccinating about a month ago, so averaging around about 300,000 rather than 600,000. And I think that tells us a couple of things. I think probably vaccine supply is more limited, given particularly because we can't use the AstraZeneca in the under 40s. I think actually the mRNA vaccine stocks have been limited, and I think that's why we're seeing reduced vaccines. I don't really see that there's much in the way of people not wanting the vaccine, although I'm not party to how many people are sort of refusing, because we don't actually know whether it's you're sort of ringing up booking for a test and it's in a month's time, or actually whether there's not that many people ringing up to book tests. I think given the UK's track record on vaccines, I think a lot of young people are still wanting to get vaccinated. And then, so therefore, if we're in a situation whereby there's reduced vaccines, one can only assume that come September, when we're starting to think about the normal circulation for winter viruses, if we have not managed to vaccinate all adults, and we'll have only vaccinated all adults with their second dose by mid-September, then we won't, by definition, have had enough to vaccinate children. And I think that's what's driving policy now, in that quite a number of people will have been deemed by the government to need to be infected effectively over the summer months, in order that we don't create this massive winter wave of COVID and flu, because that would significantly put strain on schools with sort of teacher absences, pupil absences, but also with in healthcare, with hospitals going back to sort of figures that they saw in January time, and we don't want to go back to those sort of levels of infection. So I think the UK strategy with Delta and the challenges that that's posed us has basically put us into the hard decision of essentially opening up more so than we would like, in order to bring forward the exit wave and not have it in September. But nothing really extra from Delta per se, other than that there is a little bit more gloomy figures with regards to vaccine efficacy. But still, the take-home message, I think, with vaccines and Delta is that if you're double jabbed, your risk of hospitalisation and subsequent mortality is much, much lower. And so the big measures of full lockdowns are probably never going to be needed again. It's just now on the nuanced mitigation measures of what else we should be doing. And I think the government's sort of using those other mitigation measures, their withdrawal, to try and time the peak for when they see that there's going to be less pressure on the NHS.
So there is a logic to what they're doing, even though it does feel quite scary being in schools and coming back in schools in September with what they've got planned. In terms of waning immunity, or waning efficacy, I don't know if the right term is. So people who had their, some of our school staff had their school jabs, their second one as early as Easter. So would, should they be? Will they then be targeted for a booster after a period of time, and should we be prioritising school staff, because we know that schools are going to be quite high risk environments with the changes to track and trace?
Yeah, so the data so far, bearing in mind, as you say, that we've only sort of the earliest we've had second jabs is around about Easter time. The only data we have is for the over 80s, that their immunity is waning. We also know that there are certain groups of individuals, mainly transplant recipients, that are on quite strong immunosuppressant drugs or solid tumours, cancer patients with solid tumours, whose immune systems are also hampered. That they also, it's not probably waning immunity, they probably just don't develop initial immunity in the first place. When it comes to younger adults, actually there is no evidence at the moment with regards to neutralizing antibodies. There are a small subset, but it wouldn't have a great impact. the concern is obviously that it's happening in the people that are most at risk of hospitalisation and deaths, and that's what then feeds into sort of decision making about when boosters are given. I think the pragmatic choice, given that we've had quite a successful vaccine rollout based on age, I think the pragmatic choice is going to be to vaccinate everyone over the age of 50, because AstraZeneca stocks seem to be quite plentiful, and so we know that we'll be able to fulfill that, and then anyone that's in those high priority groups as per the first round of vaccination. So if you had a teacher that was vaccinated in Easter, that might be because they're in the clinically extremely vulnerable, and they're the ones that are going to be on the list to receive boosters again.
So Matt, will the booster just be another shot of the virus that the vaccine that we've had already, or will it be specifically developed for the Delta variant?
So we probably won't have specific ones for the Delta ready by September. They are being planned. What I suspect is going to happen is you'll just have what is available, and that won't matter whether you've had, say, if you've had AstraZeneca, there's a COV boost study looking at actually whether you should mix vaccines, and there is some interesting evidence to say actually if you try and give a different type, that your immune system might be boosted, perhaps because it's sort of triggering the immune system in a slightly different way. Whether or not we actually go to do that more formally and say, if you've had Astra, should we give you Pfizer? If you've had Pfizer, should we give you AstraZeneca? I suspect what will actually happen for simplicity is that we'll just say, have whatever is available, and if it's a mix, it doesn't matter. If it's the same, it doesn't matter. The main point is we need a vaccination program that's simple to implement, because otherwise the more complexity you add in, the slower it gets. So the main point is getting as many people vaccinated as possible.
Okay, we've had a question from Michael, one of our head teacher colleagues in the Northeast, and he said that numbers are skyrocketing, and I heard yesterday that Northeast is now the growth area for this. He's asking, could there be a more transmissible variant at play here? And secondly, he's saying, and he's also saying, are the current symptoms, the same as the three classic symptoms of the raised temperature, persistent cough, and change in taste and smell?
So to answer the first question about whether there's a new variant, not that we've seen so far, this all seems to be driven by Delta. I think I would be very satisfied being in this country with our huge sort of ability with regards to genomics, that were there to be a variant that's responsible for this, and we know that there is a Delta, it's quite wrongly called Delta Plus, but we know that there's a Delta additional mutation that can be more transmissible, and that's still in India. That doesn't seem to have made much impact here. So if there is one, we will find it. Not that I've heard of so far, and so far we've been releasing data very early. If you remember back to when the Kent variant was circulating, we released that data on very early, and actually a lot of countries closed down, although they closed down because they weren't testing, and actually they all had it as well. So although it was called the Kent variant, it was just first genotyped there. So not as far as we know. The numbers of cases are effectively, because Delta, as I said to you 4 weeks ago, is so much more transmissible, and that increase in transmissibility with the current restrictions at step 3 already pushed R above 1, and now we're doing more and more, and we've got football going on, and people are becoming more relaxed, taking masks off. But as I say, that's part and parcel of the government is planning for 100,000 cases a day, and that's more than we've ever seen. But thankfully, the rate of growth of hospitalizations and deaths is not going up as steadily. Now, more transmission obviously means more likelihood for variants, and that is the big gamble. As that we've been in this position before. We created the Kent variant effectively under similar conditions, where R was above 1 and it was circulating, and now we're in a bit of a more tricky situation, in that we've got more transmission, but we've also got 50% vaccinated. So this is the time that the virus would be under greater selection pressure to develop resistance inherently to the vaccines that we're using. So it is a gamble. I'm glad I'm not the chief medical officer making these decisions. It may pan out in the grand scheme of things to have been a good gamble, but I think we need to be going into this with an open mind and saying things could potentially get quite hairy, and to some extent that's planned for.
Okay, so 100,000 a day. I mean, I've heard the statistic of 2 million over the summer will be infected at that rate. So, but then it should actually hit a natural barrier because of the vaccination, and then it should start coming down. So, and the plan is it starts to come down in the autumn term when you start getting pressures on the health service. So, yeah, fingers crossed that's going to work. In terms of schools and community spread, we're still kind of hearing this talk about that schools are a mirror of what's happening in the wider community, that schools are not vectors for transmission. That's certainly the case in my school, where we've had cases brought in from outside, but then they haven't led to pupil spread or pupil to teacher. But I do know of schools where they've had quite high levels of infection in a class. So any further developments on that, Matt?
So I think that, like the link between hospitalizations and deaths, will gradually weaken, because if you imagine communities bringing infections into schools, if it's adults that have been all vaccinated by mid-September, if they've all been double jabbed, we're going to see less transmission in the adult population, and by the definition, schools will be then quite a focus. Now, this is all in the context that children are still very rarely likely going to be sort of suffer severe disease. A fair number of them do get persistent symptoms, which we don't understand at the moment. And I think, were we to have unlimited vaccine supplies, I suspect, like other countries, they would be vaccinating 12 years and above. Unfortunately, it doesn't appear to be that we're in that situation, but there are obviously risks with switching more vaccines away from adults into children. That's quite hard to justify, given that your risk of severe disease does go up gradually as you get older, and so I think the situation probably will be changing as newer vaccines come on stream and on board. So the difficulty is that when a new vaccine comes on board, it can't immediately be used with children. It has to then go through further trials. Firstly, it has to be proved safe in the adult population, so there's always going to be a delay. But I think come September, if you think by September, all adults, double jabs that have been offered, then there's going to be less transmission. So I think that mirroring is going to be less apparent.
Okay, thank you. I mean, how do you feel as a dad with the current situation with schools and the announcements for September?
So, I mean, I'm satisfied that were one of my kids to get infection, that the main risk would have been for them to transmit it up to me or to my wife or to grandparents. That is less of a risk because we are going to have been vaccinated. I think, were they to get long COVID, I would be pretty annoyed that we didn't hang on or have more vaccine available to them. But ultimately, these are very difficult decisions. They're like, it's a pandemic that we didn't wish or hope on anyone. I think, were they to get long COVID, compared to my sort of mum and dad not being at risk from them, I think I would take that as a sort of a Hobson's choice, really. That it isn't really a choice, but I think out of all of the things, we are where we are, and we can't go back and change history. I think, were we to all do that, we'd have definitely opted for or tried to have opted for more of an elimination and hold it at bay as best as possible strategy, more like a New Zealand style, although there would have been challenges with that, with the scale of our sort of links between different countries and trade with Europe and things. It's a lot harder to sort of fully lock down the UK. But I think, as a dad, I'd be happy. I mean, I've always felt that in-school mitigations have been not a focus for the government. And I think, looking at their strategy now, I think it is a bit more apparent why that is, that they've probably always been seeing that herd immunity in kids is going to be achieved by natural infection and not vaccination, and so they've wanted to not keep a lid on it so tightly, the infection in schools, because otherwise when you get an exit wave, there's going to be massive infection in schools, and the fact that quite a lot of them have already had infection will give some protection.
Okay, thank you. Just in terms of schools and the mitigations they can take, we're going to be entering cooler weather soon, and it's wonderful in school at the moment because the window's open and everywhere's very fresh. So in terms of once we have to start making sure the windows are still open but not open quite as much, additional measures. You've talked about HEPA filters before, Matt, and I know some schools, I know a colleague in Chester's bought some HEPA filters, and there's been some chat on the Corona chat as well around that. So any more information for colleagues around HEPA filters and how they can help?
So they make entirely, like, they make sense if you, because this virus obeys the laws of physics. It travels like smoke in small particles that we then inhale and get infected by. Whether HEPA filters can make a meaningful difference to that is under research at the moment. We seem to, in this country, want to always have the answer before we act, and I'm more of a act before we have the answer, but get the answer while you're acting. So I don't think there's any, the only harm will be costs, both energy wise and the actual upfront costs for the filter. And so if the research, I'm currently working with a professor who's doing a big study in Bradford where they're putting it into lots of schools and actually looking at infection rates, having proper control schools and proper intervention schools, and then seeing actually does it have an impact. If it turns out to not have had an impact, I don't want to be on the mailing list of many angry head teachers saying we invested in all these things. It does make physical sense that if something is floating in the air, like wood fire smoke that they have lots of problems with in California, say, they employ HEPA filters to filter out the particles because they get a lot of health implications from that. This virus travels in exactly the same way, and so the problem is we don't actually know how much you need to get infected. So does reducing the dose help? I'm sure it does. Like if you inhale a couple of virus particles, you're probably less likely to get a massive severe infection than if you and I think that's why masks work mainly, because they limit the viral transmission to the upper airway rather than you inhaling a deep dose and getting the severe pneumonia. So I think they make sense. I will be trying to do something with my local school to do that. I think try and be smart about it to see actually do you have a problem to start with, and maybe club together to get some CO2 monitors that can then move around and find out actually where are your trouble spots and then fix those first, rather than just thinking it's this insurmountable problem that you just have to put HEPAs everywhere. And then likewise in hospital, we've done the same thing. So I've got 2 wards here that are kitted out with sensors, and in about 2 weeks we're going to see if putting HEPA filters on those wards actually help, because obviously I'm looking after the really vulnerable end of society that, were they to get infected, unfortunately about a third of them died from getting infection in hospital. So we're doing that study here. I think the actual guidance is quite weak. They might go to, come September, to more of a Belgian style. CO2 monitors need to be visible in public spaces, but I don't think that will span to schools. But I think it makes sense. It obeys the laws of physics. If you remove a virus, an infectious inhalable particle from the air, then it stops someone getting infected. But actually, there's so many things that come into play: fluid dynamics, and whether or not this box that's in the corner can actually remove it at a rate that's adequate is debatable.
Okay. Just Michael's second part of his question. So about the symptoms, because I've read there are additional symptoms.
There are,
well.
and this Delta variant does seem to be triggering more headache, more sort of hay fever-like symptoms. The difficulty is that when you're looking at for lots of symptoms to put in a screening program, because that's effectively what it is, you need to look at the combination of those symptoms to give you the biggest bang for your buck. Now, headache might be the most common, but if it were not associated with, so if people just had isolated headache, then that might not be necessarily that useful to stick in on a screening program, because it might not add anything to the predictive power of having the 4 core symptoms. That is being looked at by much more clever people than me, and so I still think we have to go by the 4 core symptoms, but be mindful that if you have a headache or then to look out for the other things. And actually what I would probably do is go for a test in any respect. No one is sort of, obviously they are if you go down the list, you have to tick those things, but there are other ways that you can get a test as well. So lateral flow tests, if you were testing regularly, then just bring that forward and do that, and then if that's then positive, get a PCR. I think personally, and I don't want to advocate this, but I think personally I would go for a PCR test, because that is more predictive, and it helps in the general scheme of things of fighting against this virus, because the PCRs, a large proportion of them are now genotyped. So were it to be a new variant that you have, then we would find it.
Yeah, the parents in our community have been really good since we had those multiple cases early in June, that they've been going and getting PCR tests for some of those additional symptoms as well. So it has certainly started to suppress numbers in our locality. Joe, I'm looking at you now to kind of distill the medical questions for Matt and leave some of the operational stuff for me and Dan and yourself and anybody else who can help. So Joe, have you got any specific medical questions for Matt?
First of all, what's an exit wave, Matt?
So the exit wave is just the wave that you get when you open up. So if you imagine lifting Pandora's box, that's the virus finally escaping all the mitigations that are reducing R, to find all the people that have either chosen or not able to have a vaccine, or in whom it hasn't worked.
So what we're expecting coming up from the 19th of July then?
So the maximum predicted is around about 100,000 cases a day. The maximum hospitalizations is predicted to be about 20,000 a day, up to 20,000 inpatients. So that's about half of what we achieved last time. And that's the reasonable sort of, there are obviously more doomsday scenarios that go into whether or not people will completely choose to change their behavior back to where we were. And I'm not as pessimistic as that model. I think people will be sensible. I think the vast majority of the country, although you still see people like newspapers love putting pictures of people being irresponsible on headlines, but I still think people will be distancing, and I still think the vast majority of us will be wearing masks in enclosed spaces.
So if we wear masks in closed spaces, then it's going to relieve some pressure on the health service. That's a public good of doing some of the measures that we've been doing so far. Okay.
Yeah, it's a choice. The guidance is still going to be the same. It's just it's not going to be a legal requirement. So I think the guidance is there, and I think it's our civic duty really to adhere to the guidance.
Yes, of course, and to help support you working out, because of course you'll have a backlog of patients and treatments which are not going to get treated in the summer, because you're going to be dealing with tens of thousands of inpatients. So, okay, Joe.
A little bit around pregnant, expectant teachers or teaching staff, if they've chosen not to vaccinate, and if there's any stats on pregnancy and the effects.
So I circulated this last time from the Royal College of Obstetricians. There's very good sort of guidance on pregnancy and vaccination. From what I read, the risks of not being vaccinated in the current situation. So you could have argued maybe in low prevalence sort of scenarios that actually your risk from possibly a vaccine that hasn't been tested for so long in pregnant women versus COVID, because obviously there wasn't so much COVID. I think now that we're in a situation whereby there's going to be lots and lots of COVID, I would just urge them to adhere to that advice. There's lots of really good frequently asked questions on their website that I circulated around last time, and I would urge them. I think if my wife was pregnant and she opted not to, I think I would be still pushing for her to be vaccinated now.
Is there any change in the number of children becoming seriously ill, and are there any stats on long COVID in children?
So the rates, with all these things, it's very important to think of the rates of change, because obviously as more people get infected and we get more cases, there will be more children just by the very nature that there is more virus. There is some data in adults that this Delta variant leads to more severe disease. But not that I've seen in children. However, the proviso is that not very many children get severe disease anyway, and so we're talking about differences in very, very small numbers, and so we won't really know that. It's one of those things, unfortunately. I remember our first Coronacast when sort of saying a lot is unknown, and then even by December we were only just starting to get information about what summer did and what sort of opening just before summer did. It's one of those things that we just will not know the full answer to until it's happened, unfortunately. But I mean, it might make reasonable sense if it's more severe in adults that we would be cautious about it being potentially more severe in children, but it's a very small number to start with. So your absolute risk will be, it will be very unlikely to have a meaningful impact on that individual child. But taken as a whole, I think we are in a situation whereby we are unfortunately going to see more illness with children, but that's part and parcel of the pandemic where we are.
I don't know if you're an expert on this, but there's a few questions around the CO2 monitors and what constitutes kind of safe levels.
So I've had to become a bit of an expert because that's exactly the same study I'm doing in the hospital. But I can tell you exactly what Kath Noak says, and she's a member of SAGE. So she says if you get levels under 800, then that is indicative of a well-ventilated space and that you don't necessarily need to worry. If all your areas are 800 or below and you still wanted to do HEPA, then just choose the higher number. If you're getting anything over 800, then that shows that you're sharing the air of people that have breathed out quite heavily, and therefore you need to think about simple things first, because they're free, well, apart from heating in the winter, but like opening windows and trying to improve cross ventilation. You can employ simple fans, sort of sucking air in or blowing air out as a simple measure, which anyone can do. That's the sort of thing I do here. So I've got a fan here, and when I'm sharing the office, I open the window and actively blow air out of the window to improve the sort of natural ventilation. And then if you have real trouble spots, then considering HEPA or HEPA combined with upper air UV. We're actually going to use HEPA filters with UV actually built into them. We don't know which ones are the best, and they all seem to have reasonable. There's good data from America that HEPA or UVC all combined seems to be effective. Now, this is not the wands. I remember you asked me on a very earlier Coronacast about these wands that you disinfect surfaces with, because we don't think that this is surface spread. I wouldn't bother with those, but this is a fan effectively that sucks the air through a UV filter to effectively make breaks within the RNA of the virus, so that if it were to infect you, it doesn't cause disease.
What's a unit for that, Matt? 800?
800, I think it's parts per million.
Okay.
Don't quote me on that. I'll check, and if it's not parts per million, I'll email you.
Okay, that's great. Okay,
Joe, all the
how
same. If it's a CO2 monitor, it will all be the same unit.
Will it be the same? Yes.
Yeah.
Okay.
Matt, I just think you're amazing. You're an absolute font of information.
I only know that because I had to look it up. I wouldn't have known that if you asked me that 2 months ago.
Yeah, thank you so much. Because you just make it really, really easy for us to understand as non-scientists. So,
because I'm a simple person.
No, not at all.
Come on, Joe, stop flirting. We've got to crack on with business.
Thanks. That's it.
Oh, right. I have got one more for Matt before he goes. Matt, so when we go back to the guidance is that we're effectively we're not going to be doing the contact tracing in school, because they're going to ask the positive case who they've been in contact with, and anybody who's worked with a 4-year-old will know that they won't have much idea who they've been in contact with. So effectively, contact tracing within schools is going to go. What are the risks of that in terms of the operation of the school? Clearly, it's going to help us because we're not going to have as many children being sent home in balls. What are the risks of an outbreak happening in school with this system that's going to be happening in September? So
I think what we know, so the disruption will be almost certainly lower, because the vast majority of children who are sent home are not infected and don't end up getting infection. The risk is therefore, I mean, you will definitely then get more infection in schools. That just will happen because cases are going up. So the number of people that are testing positive, you might end up, instead of sort of 1 every 2 days or 1 every week, I don't know what some schools have been getting, but in the whole school, but you might end up sort of getting a daily case pop up, and you might then, but just by the law of averages, getting some cases that converge, and so you might get 2 cases that then become infectious at the same time in the classroom. Now that will mean that there is more virus in individual class settings, unless you do much more mitigation. So because we're not talking about masks are not being mandated in this country for reasons as we've discussed, and I suspect HEPA UVC won't be mass rolled out across the education system, then we will get more infection within classrooms, just because we're in this case of a growing pandemic again, but we're in a different setting in that we're not doing any form of lockdown. So this is effectively the last hurrah it's Freedom Day for one person only, and that's the coronavirus. It's not Freedom Day necessarily for us, because you will see more infection, but it's a calculated gamble that they've chosen to do it over the summer. And you've only got sort of 3 more. How many more weeks have you got? To go, is it 3 more weeks?
Maximum, I think most schools have got 2 weeks.
Okay.
After this, right? Some have only got a week. So
yeah. So I mean, we are still going to have the current mitigations in place till the 19th. So I think for you, up until the summer, I think you won't see much of it. I think come September, it really does depend a lot on how much the vaccine evasion there actually is, because we don't actually know how much evasion there is going to be for AstraZeneca. We know that it's probably 64% for Pfizer. Is that the same? I don't know. And so it depends how much of the exit wave carries on into the September. But I think the reason for the 19th of July is to try and get most of the exit wave out of the way, so that when schools open, herd immunity has been achieved.
Final question, Matt. I did see something pop up on the chat from Louise about clinically extremely vulnerable staff in schools as well. So there's been no further guidance around that for clinically extremely vulnerable. As employers with a duty of care for the people that work in our buildings, what should we be looking out for, and what can we do?
So I think that really does depend on what's happening locally. I think were I to be clinically extremely vulnerable, were community cases to be going up, and were we to have active cases of infection in and around sort of my bubble, I would be wanting to limit my risk as much as possible, because particularly if you're in the at-risk groups from the vaccines not working, the ones that I've particularly mentioned, and there's lots of guidance on the NHS website about who particularly you might expect that. I would be surprised come September if there isn't any advice on that. If there isn't, then maybe we could sort of talk about that a bit more in detail, but I suspect come September there will be much more advice about what to do.
Okay,
and if there wasn't, I would push your union to push that point, because I would expect there to be guidance.
Yeah. Okay, Matt, that's great. Okay, Matt, we've finished on the medical questions, so we're going to talk about some operational stuff. Oh, Joe, there's one more.
A couple of people have just mentioned about you mentioned about the surfaces, because I know lots of people are still having extra cleaning, etc. I'm paying out for extra cleaning. So they're
The-
asking whether
The document yesterday, Joe, said that we're still to do enhanced cleaning. The document that came out yesterday, so that answers that question.
It's good for other infections.
It is. It's been great for colds, hasn't it? So
yeah,
yeah,
and norovirus.
Yeah. Okay, Matt, you're welcome to stay with us, but
I might leave.
But if you want to leave, because it looks like you're busy. Okay, yeah. Matt, lovely to see you. We must have that pint very soon. So we
I'm thirsty.
Yes, we must go. But you take care, and thanks so much for all your input this year.
All the best, everyone. Stay safe.
Take care. Bye. Okay, Joe, how are we doing with any operational questions that we can hand over to Dan?
Lots of questions about what's everybody doing between the 19th and breaking up.
Well, we're finishing on the 16th, which isn't really help, so I'm going to hand Dan over to this one.
Yeah, so I think yesterday's announcements were pretty much saying you can keep all your measures that you've got in place until you break up. So, you know, as a trust, we're definitely going to just be keeping everything in place that we've had. We've got 3 or 4 days the next week where we're and it'll just confuse parents. I also think that, you know, there's a real rationale for protecting parents who have booked holidays, you know, for that as well. So I think we'll be communicating out to parents that we're keeping all of those measures. I think in terms of an outbreak post the 19th of July or a case, the guidance says, you know, we won't be involved in that track and trace during that time, after that time. However, I believe, and it was reported in Schools Week, that Gavin Williamson has said that, you know, we can carry on with the isolation as we have been. Now, what we're going to be doing is referring to our local public health around that, and just to check that measures, because we can't be going against the guidance around it. And also, this has been quite public in terms of the announcement, so we don't want to be alienating parents. So what we're going to do is to be checking with, we'll be checking with Cheshire East around the actions that they want us to take around that. But in a sense, just for those last few days of term, we're keeping everything the same. We're not going to change anything.
Really important point there. I know Cheshire West colleagues, we've got a meeting with Kerry Ann at 3:30 tonight that's been called. We are an enhanced support area in Cheshire East and West, which they don't seem to have brought new ones online. I know Michael from the Northeast has let us know that Northeast, but they've not brought in new areas. But there's been no guidance yet issued for local public health teams around enhanced support. So we must work in partnership with our local health, because I think if you go against the guidance without support of your local public health body, you're leaving yourself vulnerable, you're leaving yourself exposed to challenge there. So please don't make any unilateral decisions which are away from the guidance without the support of your public health teams, because they know what the picture's like locally. Joe.
Do we know what's classed as an outbreak?
An outbreak used to be 2 or more cases.
In the guidance, they've used the really helpful term of several. So I think that the clear answer is no. But again, I think we've got to be guided by our public health teams to have that information. So I'll be reporting, you know, make sure we continue that reporting back to our local public health, because I think they will be the ones who make the decision whether it's an outbreak. And just following on from that, somebody's asked me regarding, are we just assuming that if the bubble stays open, then we're presuming we're going to get more cases? And I think, you know, we will get more cases. And just listening to Matt, I do think that that's the government tactic, actually, is that, you know, getting it to run through children is what we're looking at. So I think that we will presume we'll get more cases spread, but we aren't seeing necessarily that picture of spread within the classroom as it is.
How to manage a clinically extremely vulnerable person who can't be vaccinated?
I think it goes back to Matt's question and see what guidance we have for September for that, because it's you know, we need to have, and talk to your HR people as well, because that's I mean, I would certainly personally be looking at home working for that individual, but some jobs, when we've got one who's but has been vaccinated, but we had a cleaner who was clinically extremely vulnerable, and of course that was quite difficult to give her home working opportunities. So consult with your HR over that, and we will press as a union with the other unions for additional guidance for those people when we come back in September.
I think just on that as well, it's really important that those people have an individualised risk assessment, just to really, make sure that they feel that they're consulted and safe on site. But again, we would advocate home working, and we have done currently.
Somebody's asked, a child tested positive, self-isolated and came back after 10 days. The parents were then coughing but tested negative. Should they be testing again? They did the test at day 8 and when they were negative.
Yeah, I would recommend the parents do that. We can't force them to do it, but they should certainly be. And we have seen some cases. Jan Diamond, who's on the call today, who's the head of school at Hertford Manor, she had a 14-day incubation period between seeing the virus. So and Jan isn't an isolated case, so it's safety first, and knowing that the 10-day is in the new Delta variant is there are examples of it being extended beyond the 10 days.
And finally, are people planning on keeping bubbles in some form in September or totally abandoning? So I think that's just getting a general consensus.
Yeah, the guidance says that we're not to use bubbles in September quite specifically unless we're advised to by our public health board. So you would be, but you ought to have plans in place to rebubble. So the plans are that's what it says. So the guidance, it doesn't expect you to bubble unless directed to by your public health teams locally. So. Anything else, Joe?
I think there's just one come in at the end from Andrew. If we, and it kind of goes back to this, but if we are, wanted to keep some consistent groups and staggered time from an interim period, is that our prerogative to do so?
The guidance doesn't say that. It specifically says we shouldn't have staggered starts. So I think you then have to liaise with your public health people if that's what you were planning to do. I mean, one of the challenges I think is that a child gets it, and then track and trace get in touch with the parents and said who was Johnny in close contact with for the last 48 hours. Parents are going to automatically say, well, I don't know, he was in school. So they're going to then phone the school. So I think we need to make it very clear to parents that the government guidance is that we shouldn't bubble from September unless public health advises to do so. So we can't get involved in the contact tracing from September, because the only way we can actually say who Johnny's been in close contact with a certain degree of accuracy is if we have small consistent groups, and the guidance is specifically saying we shouldn't. So yeah, I don't go out on a limb on this, because you could have some real challenge from parents around this, because we've got to adhere to the national guidance unless our public health teams tell us not to do that.
The guidance actually says we would only be involved in extreme cases.
Yeah.
So we need to be careful, and
that will be when you've got an outbreak in school, or where you've got lots of stuff going around in the local area. So that's when that would happen. But you'd have plans to go back to your bubbling and additional measures like face coverings if needed.
And again, there's a question coming around whole school assemblies and everyone back eating in the hall. Again, that's been we've been told that we should be going back to those.
Yeah, I'm gonna continue with a staggered lunchtime, Dan, and staggered hall, because we've seen a big increase in our behaviour. The behaviour's been great because we've had less children in the hall. We've had more space for playtime. So that'll be the rationale that will be if we keep a staggered lunchtime. But we can't do it because of COVID. But it's worked pretty well in our school, having less children outside and less children in the dining hall. So that's something I think I'll keep.
But yeah, the whole school assemblies, it does say, we can return to whole school assemblies. So
it does.
So
it's going to feel very alien in September for many of us who've been operating in this way now. It feels like normal, doesn't it?
Yeah, I guess. Sorry, I was going to say, I guess if some of the mitigations you have in place have helped things like behaviour and logistics, then that's a rationale to keep them. And somebody's just asked about parents asking to keep the staggered starts. I think if parents are asking, and I think if it's around behaviour and logistics, I don't see there's any harm. I think we've just got to be careful it's not part of going out on a limb for COVID restrictions.
But if you are changing your end and start times of the day, you do have to go out to a proper consultation and do that formally. So, so that's something just to be aware of.
Yeah.
Face coverings as well. I mean, I suppose I'll be talking to our staff this week about face coverings and what they want to do, because everybody in my school, we've always said you can wear a face covering if you want to. So we will come to a view on that as a staff, because we may decide we want to do that in those communal areas where we've got adult to adult contact, but then again we'll all be double jabbed as well. So we may decide we don't wear face coverings when we're having adult to adult contact, but we shall have a think about that, because it was interesting. The chief medical officer said he would be wearing a face covering in indoor crowded spaces. So that's quite a lot of the spaces that we work in, isn't it, within our schools? So I'll be talking to staff about that.
And the Carl's just put a question about staff who chose not to vaccinate, and I think this is going to be quite an interesting area, because staff who have been double vaccinated won't need to self-isolate if they're a close contact, but those who haven't been double vaccinated will. So we're certainly going to be consulting with our HR about how we build that into our staff absence policy, because it's clear that that's going to have an impact on finance if staff need to be covered because they've got to self-isolate. So I think it's consulting with HR, your HR provider, on that, and making sure you've got a clear view as a school around how you're handling that.
Yeah, that's an interesting one, Dan, isn't it? I can see that being quite a thorny issue come the autumn term, if people have to self-isolate because they've chosen not to have a vaccination.
And there's a question about, is there any information on parents being in classrooms? The only information we've got is that if we're having any visitors on site, they don't need to wear face coverings. So again, I think it's something that you need to look at and see how safe it is. But I know we're going to have parental volunteers wanting to come back in. Soon.
Yeah, and there might have to be some sort of waiver as well, because when we have the people from the local church do a reading scheme with our children, and they're quite elderly, quite a few of the people that were coming into school. So we'll have to have a think about that and risk assessing those people that come into school.
And Jay's just asked, are we allowed to ask visitors to wear masks? The guidance says the visitors don't need to wear masks. So I guess that's going outside of the guidance, but I think we can suggest wearing masks, but I don't think we can enforce. Do you agree, Simon?
Yeah, it's again, public health might be able to assist with with that as well, but
yeah. And testing, LFT testing for visitors. Are we asking visitors to LFT test? Again, I don't think there's a requirement.
A requirement for that. I mean, but we do know that with certain venues and certain things can actually go and put in restrictions. I remember not being able to get into somewhere in Stoke because I wasn't wearing the right kind of shoes. So organisations can go and put restrictions on who they allow on their premises. But I wouldn't do that unilaterally as a school without talking to your local authority. Or local public health people, because we just need to be really careful, because I think we could have quite a lot of tension if we're putting in things that aren't in national guidance. How are we doing, Dan?
Yeah, I think that's it. I think Claire's just said the guidance says LFT until the end of September in place for students.
So it'll be reviewed, I think, isn't it, the September? So LFT for secondaries will be reviewed at the end of September. And I'll still be encouraging our families. And when we had the outbreak locally, I encouraged families to go back to revisiting again, because there was real drop off at secondary level when I think about 20% were doing them, as the statistic I picked up. But there has been a big increase in participation around that. So I'll be asking families. It's about goodwill, and asking families to still do the LFT tests.
And there's a question around track and trace for 6 days after we break up, but I believe that that's gone. We won't be involved in track and trace after the 19th of July. So I think the old guidance was we had to track and trace for that time after schools broke up, but there won't be a requirement moving into.
Dan, what's the difference between the July date and the August date, which published yesterday? Because I've not given that much attention because our school's finishing on the 16th.
So the August date is when people can stop self-isolating when they become a close contact, I believe. I haven't given it a huge amount of date, but the track and trace as schools, we've certainly been told that we won't be involved in that. Following the 19th of July.
That'll be track and trace people who will
yes,
then
pick up
the baton.
So Debbie's just said they've had an email this week about the 6 days, but I believe that from my reading of the guidance and everything that's come through since, we won't be involved in track and trace for that, into the summer holidays. So I'm not sure where that's come from. I know there's some mixed messages going on. I know we've had in one of our schools a child return from Poland this morning, and the customs people told them they could come straight into school with no self-isolation, which is not a helpful thing. So I think that we need to just get clarity on this guidance. But I think the track and trace is quite clear. But if anyone wants us to follow that through. Debbie, if you want us to follow that through and just get clarity and email it out, then just if you could forward me that email, we'll have a look at that, because I think it's helpful to make sure we don't have mixed guidance.
Okay, I urge everybody to get a meeting with your public health lead contact person as soon as possible as well, because they've been certainly in Cheshire West, they've been absolutely amazing throughout this. So just make sure that you get a meeting with them as soon as possible, so you have that security for going into the summer. Okay, are we good, Dan?
Yeah, I think Catherine's just asked about risk assessment September. I think you're basically going to have two, one for the new guidance and one in case you are asked by public health to go back to the
old guidance. But I think your contingency plan that it talks about in the guidance is basically those different mitigations that we're well versed at now, that you might have to go and put those things in. Okay.
Yeah. And I think the risk assessment can be your outbreak management plan. We've certainly combined the two, and that's just the way it's gonna sit. So not duplicating work. So.
Okay.
Smashing. Okay. I think we're done. So.
Oh, Dan, there's some clarification there, which is really helpful if people want to stay and read Mr. White's comment around that, because I'm not sure it was that clear.
Okay, so the 6 days is after if your breakup before step 4 starts, then you're still expected to do 6 days. Contact tracing is the way I'm reading that.
But it says from step 4.
From step 4 or 6 days after term ends, whichever is the earlier. So okay. At step 4, our responsibility stops.
Okay, everybody, nice to see everybody, and we will let you know if we're having another meeting before we break up, and if we don't, hope everybody can get a bit of a restful summer and get ready for September, where it looks like we're back to normal, but it's gonna be quite scary, but I'm sure we'll be here to support each other and help each other along the way. Okay, take care, everybody.
Thanks, everybody.